Good morning, everybody, and welcome back to this very exciting Journal Club session today. It gives me great pleasure to say we are live from the University of Catania in Italy, and we'll be discussing the issue of short DAPT therapy after PCI in acute coronary syndrome. Our presenter today is Giovanni Occhipinti from the University of Catania, and as our expert, it's a real pleasure for us to welcome back Professor Davide Capodanno, who is a real expert in this field and with this topic. So Giovanni, if I can invite you to share your screen, and in the meantime, we'll give a few more seconds just to finish the poll, and then we'll announce the results. So just as we get started, let's just have a look at the results of the poll. So the poll was, which is your preferred antiplatelet strategy in high bleeding risk patients undergoing PCI for acute myocardial infarction? So the overwhelming majority have gone for shortening DAP duration, with a greater preference, about 50% of respondents stopping aspirin early, the rest opting to stop P2Y12 early, and very few people going for a de-escalation strategy. And a few people, and I'll put myself in that category, saying that I'm confused. So Giovanni, please, looking forward to your presentation, and hopefully the discussion will enlighten us all. Sorry, Giovanni, I think you're muted. If I can just ask you to start again, please.
Okay. Good morning, everyone. Thanks to the Journal Club editorial board, who gave me the possibility to be here this morning, and to my mentor, Professor Davide Capodanno. Our meeting today will be focused on short duration of DAPT versus de-escalation after percutaneous coronary intervention for acute coronary syndrome. Okay. As a background, I want to remember that in patients with acute coronary syndromes treated with stent implantation, DAPT with a P2Y12 receptor inhibitor is recommended for 12 months unless there are contraindications such as excessive bleeding. Bleeding risk represents the main issue of DAPT and has been associated with increased mortality. At date, two strategies of bleeding mitigation have been proposed and involve shortening DAPT duration and de-escalation of the P2Y12 receptor inhibitor. As a fact, in the latest European guidelines, as you can see in the right part of your screen, classes of recommendation for short DAPT and de-escalation obtained 2A and 2B respectively. In the last years, a number of meta-analyses underscored the benefit of short DAPT and de-escalation compared with the standard DAPT. However, due to the lack of direct comparisons between short DAPT and de-escalation, it's not possible to directly address whether one of the two strategies is preferable. What can help us overcome this limit is represented by network meta-analysis. NMA is a development which extends the principle of pairwise meta-analysis to the evaluation of multiple treatment in single analysis, as long as they have the same comparator, in this case represented by standard DAPT. This is why we jumped into a network meta-analysis, aiming to evaluate relative merits of short DAPT and de-escalation. The slide now I'm showing you the architecture of our study. Okay, the first step was made questioning the three main science databases, Medline, Cochrane, and Web of Science, asking for randomized clinical trials with the following characteristics. We were looking for an ACS patient undergoing a PCI with DES implantation in the main analysis, or randomized clinical trials reporting an ACS subgroup analysis. For the experimental arm, short DAPT, intended as the discontinuation of the P2Y12 inhibitor or aspirin at 1 to 6 months, and the escalation from a potent drug, either prasugrel or ticagrelor, to clopidogrel or to their half dose, were chosen. All of them compared with the same comparator, standard DAPT. In terms of clinical outcomes, we included ones that were reported at 6 months or more. And among those, we focused on measures of net clinical benefits, including all-cause death, that was our primary endpoint, and then thrombotic and bleeding endpoints. For bleeding endpoints, we prioritized the Bleeding Academic Research Consortium scale, or when not available, the TIMI scale. The screening process allowed us to select 29 studies and a total of more than 50,000 patients. In order to establish transparency, the risk of bias assessment was performed through the revised Cochrane ROB2 scale. We also used the Egger regression test and the visual inspections of funnel plot. Through the ROB2 scale, we identify a high risk of bias in 7 studies. This led us to pre-specify sensitivity analysis, including omission of trials at high risk of bias. At the visual inspection of funnel plot, it was not possible to, as you can see in the right part of your screen, it was not possible to identify asymmetry. And also, all Egger tests proved not significant for risk of bias. Regarding the transitivity assumption, it was satisfied comparing the distribution of age, sex, diabetes, and death in the control arm across trials. At the end of our billing process, we defined the treatment network, evaluating treatment both at the strategy level in a 3-node network and at the drug level in a 5-node network. In this network, the MOS comparator is represented by standard DAPT, as you can see in yellow. The direct comparisons are represented by gray lines, as you can see. But in both networks, there are no closed loop due to the lack of direct comparison of a short DAPT and de-escalation. Our statistical analysis was conducted using for first, a frequentistic approach, recurring to fixed or random effect model based on the heterogeneity among studies. We set a cutoff point of 50% or more in terms of heterogeneity to use a random effect model. We also decide to apply a second analysis model, the Bayesian model, in order to compare results and find any search of inconsistency that could emerge from the previous approach. Moreover, a Bayesian approach allowed us for ranking of interventions, calculating the probability of each intervention taking a particular rank. Going over the result, the bivariate analysis that include the whole data without any ad hoc continuity correction gave us the possibility to appreciate how both investigational strategies, short DAPT and de-escalation, when compared to standard DAPT in a 3-node network, resulted in a reduction of MACE and clinical relevant bleeding, with the largest reduction in MACE provided by de-escalation. Here in this panel, okay, I show you the forest plot of the indirect comparison of short DAPT and de-escalation. As you can appreciate, the risk for all-cause death was similar. Conversely, de-escalation reduced the risk for NACE and significantly increased the risk for major bleeding. No significant risk differences were observed in all the other secondary endpoints. The result of the Bayesian analysis were consistent with the frequentist analysis. There was no differences for all-cause death, but de-escalation reduced the risk for NACE and increased the risk for major bleeding. Through the Bayesian analysis, we were also able to perform rankograms, how it was previously announced. As you can see, de-escalation was associated with a high probability to rank as the best treatment strategies for NACE, myocardial infarction, stroke, stent thrombosis, and minor bleeding, while short DAPT had the greatest probability to rank as the best treatment strategies for major bleeding. When the node split analysis was performed, the bivariate analysis reconfirmed the trend of reduction in clinically relevant bleeding. In this setting, short DAPT with a discontinuation of the P2Y12 receptor inhibitor, thus continuing aspirin, the one that you can see in light blue, appeared as the worst treatment among those analyzed, and also was the only that result in a slight increase in MACE. In terms of results, no differences were observed for all-cause death compared to short DAPT with aspirin continuation. Both de-escalation to clopidogrel and de-escalation to alpha dose reduced the risk of NACE. No differences in major bleeding were found. In terms of minor bleeding, de-escalation to alpha dose reduced the risk compared to short DAPT with aspirin discontinuation. The corresponding Bayesian results were consistent. Finally, rankograms showed how the escalation to alpha dose was the most probable strategy to rank first with respect to all-cause death, NACE, MACE, cardiovascular death, myocardial infarction, stent thrombosis, and minor bleeding. Conversely, the escalation to clopidogrel was the most probable strategy to rank first with respect to clinically relevant bleeding and major bleeding. Okay, here I show you the results of our sensitivity analysis. And we can say that in all the sensitivity analysis, the results of the indirect comparison were unchanged for all-cause death, cardiovascular death, myocardial infarction, and clinically relevant bleeding, and also minor bleeding. The direction of the treatment effect of the de-escalation for NACE was not excessively influenced in each sensitivity analysis, but was larger in magnitude in studies of East Asian patients and studies that reported a randomization at 1 or 6 months, from 1 to 6 months. The risk for stent thrombosis was numerically reduced by the escalation, with a possible exception of studies with the same problem, with the same issue, the randomization between 1 to 6 months. Major bleeding was increased with the escalation in all sensitivity analysis, with the exceptions of a trial that used clopidogrel in the standard DAPT arm. In conclusion, among strategies of DAPT modulation for patients with acute coronary syndromes undergoing PCI, we found no differences in the risk for death between short DAPT and de-escalation. De-escalation was associated with a reduced risk for NACE, while short DAPT was associated with a reduced risk for major bleeding. Thank you.
Great. Thank you very much, Giovanni. Very nice presentation and a very nice summary as well of this quite detailed paper. Could I please invite Professor Capodanno, if I can please invite you to share with us your insights into this paper and also how it fits into this growing field, please.
Yes, thank you very much. And first of all, I would like to thank the Journal Club editorial board for hosting this paper on behalf of my research group here in Catania. And Giovanni was a great part of it, of course, as you have just heard. So I would like to explain a little bit more about the rationale for having a meta-analysis like this in this particular moment of the field. And also, if I may, a methodological note, because we are in a journal club setting, and maybe something about the implications of these results in our humble view. So let's say, you know that the antithrombotic field is complex, as we have said during the poll results presentation, and I agree. Of course, we didn't simplify too much with the network meta-analysis, which actually adds granularity to the topic. But we felt that at this stage, we have enough evidence to support short DAPT versus standard DAPT for selected patients. And we have enough evidence also to support de-escalation versus standard DAPT for selected patients as well. What we miss is really the comparison between the two strategies. And of course, people start to be confused. Should I select de-escalation? Should I select short DAPT if I have a high bleeding risk patient? So that was the rationale for the meta-analysis. It is a network meta-analysis because we decided up front that probably there is no evidence whatsoever comparing directly the two strategies. And in fact, this is what we found in our search. So with the network meta-analysis, you can really combine all the studies to assume that there is a kind of artificial comparison between two strategies that were never compared. Of course, in the hierarchy of evidence, this is suboptimal as compared with the direct comparison. So, of course, we much hope that this comparison will be done one day or another. But for the time being, this is what we can do. It is very important to say that this kind of comparisons are possible only if the so-called transitivity assumption is fulfilled. What does it mean? It means that the studies comparing short DAPT versus standard DAPT must be somehow similar in terms of the case mix of patients and the treatment effect as compared with the studies of de-escalation versus standard DAPT. And of course, when we found that this is actually fulfilled, we were happy to see that the population is similar, a similar mid-age, we have a similar proportion of male, a similar proportion of diabetes, and also the mortality in the control group is similar. So this means that in a way we can trust indirect comparison, of course, within the limitation that we have set. So this is just to say that this is not rocket science, it's not kind of magic, but it's something that is based on some assumptions, and of course, as any meta-analysis is prone to criticism and also discussion. In terms of the implications, so you have seen what Giovanni showed at the very beginning, the current guidelines 2020 for acute coronary syndromes in Europe. The next ones are announced already for 2024 and will incorporate many trials that didn't enter the past guidelines in 2020, of course, because they were not presented or published. One, for example, is the famous Master DPT trial, which is not in the current framework. So you have seen that for short DAPT, we have a 2A class of recommendation, level of evidence A, and for the de-escalation, we have a 2B recommendation. So the first implication that we suggest in the discussion is that we don't see a reason why de-escalation should be 2B and short DAPT should be 2A. So for us, they are at least at the same level. You may say maybe 2A, maybe 1 for high bleeding risk patients, but actually the mortality was same in this indirect comparison. And there are some relative merits of both in a way, because we have seen that the short DPT reduces major bleeding, de-escalation reduces MACE, and ischemic events. Why? That's quite clear to us because essentially with short DAPT, you abandon one antiplatelet and you stay with one. With de-escalation, you change one antiplatelet, but you stay with. So it's not surprising that in a way you continue to have some effect from DAPT in the long term and maybe less bleeding. But of course, if you go for single antiplatelet therapy, you reduce bleeding. So I think there is some evidence now that you must select the right strategy based on the type of patient that you have, which is something that we call personalized medicine in a way, and I think is the way to go. I would like also to mention that, of course, that is a matter of practicality. For the short DAPT, first of all, we have two options. We can abandon the aspirin, we can abandon the P2Y12 inhibitors. Our meta-analysis, of course, cannot address this question, but we have some initial evidence from trials like OSTEXAM that when you have to abandon one antiplatelet agent, probably it's better to stop aspirin and continue with the P2Y12 inhibitor, which makes a lot of sense to me, particularly in the ACS that we are discussing today, because if you stay with the ticagrelor or prasugrel monotherapy, probably this is enough for many patients. For the de-escalation, of course, the issue is practicality, because we know that the de-escalation can be unguided, but can be also guided, and preferably probably because the evidence is stronger there, which means that you have to use the platelet function testing, which is not widely available, and genetic testing, which is even more complex. So, of course, we are discussing in theory now, but then there is an action in implementation, which is, of course, something that we'll need to follow. Finally, I would like to mention that one de-escalation strategy that appeared to be the best, according to the rankograms that Giovanni has shown elegantly, is the de-escalation to the halved dose, which is something that was explored in very few trials that we found among these 29, but it's very interesting. So essentially going from a higher dose to a lower dose is something that has been attempted in Asia, in particular, where they have a high bleeding risk, but it's worthy of being investigated, I think, also in non-Asian populations, because it means that you just decrease the potency of the antiplatelet without abandoning the antiplatelet. So it's worthy to be seen in the future, and in this meta-analysis, what suggests to be one of the best strategies, of course, with very small numbers. So I think this is what I wanted to say. I'm very happy to take your questions, if any, and again, thank you very much for having us.
Great. Thank you very much for that summary. So we're very much open to questions. If anybody would like to ask anything, please either type them or do come onto the screen and do ask your questions. Very happy to take them now. Professor, one of the things we like to discuss in the Journal Club is a little bit of methodology, because we've got all these young fellows and residents from all over connected. You've already touched on the differences, let's say, between network meta-analysis, and we're starting to see this a bit more. I would like to ask you this. You presented, or Giovanni presented, this concept of frequentist versus Bayesian. If you could just give us a little overview of what these terms mean, and what is the, let's say, relevance for us if we are reading a paper which mentions these two different things. How should we think about those?
Yeah, thank you very much. So we can say that most of the meta-analysis that you see are frequentist. So this is the standard methodology for meta-analysis. It's a typical combination of events based on numerators, denominators, odds ratios, other ratios, etc. So most meta-analysis are run in a frequentist framework. The Bayesian methodology is something that is emerging more and more. Some people advocate that this should be the first line methodology for meta-analysis, and essentially is a different formula and calculation that use prior assumptions. So of course, I will not go into details to not confuse more, but essentially this framework is more robust in a way that is also more conservative. And of course, the idea in this meta-analysis was to use both in order to see whether one was consistent with the others. Because they were consistent, we assume that our results are a bit stronger than they would be just presenting one or the other.
Okay, thank you. So maybe we can now take some questions. So the first question from Alessia is about short DAPT therapy in patients with STEMI. Is this a safe strategy, and in whom can we consider this, if anyone?
Thank you, Alessia. Well, there was one dedicated trial, and it's included in the meta-analysis about this very specific question, which was called the DAPT STEMI. And basically, they compare 6 months versus 12 months. When we analyze this trial in our risk of assessment analysis, we found that it has quite large sample size. And like many trials of short DAPT duration, it's not conclusive on the topic. They found that there was non-inferiority for 6 months as compared with the 12 months, but in the end, this is affected by the large non-inferiority margin, which creates a regression towards the neutrality, as frequently happens in these small and underpowered trials. However, when we look at the totality of the evidence, our feeling is that the short DAPT strategy is still possible if you stay with the P2Y12 inhibitor, not clopidogrel, but ticagrelor. This is indirectly, not in STEMI, but in ACS, shown also by trials like TICO, while we have recently seen from DAPT2 ACS that with clopidogrel, this probably will not work. So I think that staying with the ticagrelor monotherapy after 6 months is something we can consider in selected patients that high bleeding risk.
Okay, thank you. Next from Antonella about patients with Minoca. Something about regarding the antiplatelet medication and the strategy, because there's perhaps lack of clear guidance or any strong consensus documents. So how would Minoca patients impact your clinical practice with antiplatelets?
Thank you very much. I think, so we have recently published a review on antibody therapy in Minoca. The first author is Luis Ortega Paz, another young colleague. So in the review, the point that we make is that it's very relevant to pose a diagnosis. And we know that with Minoca, from the ARC Minoca study, if you perform OCT and cardiac magnetic resonance, you achieve a final diagnosis in 80% of the patients. So I think not doing so is a missed opportunity, because the things that you can discover at OCT and cardiac magnetic resonance in the end will affect your antithrombotic strategy. If you find an erosion, for example, as a cause of Minoca, then of course there is some rationale for antithrombotic therapy. If you find myocarditis at the end, then there is no rationale. So I think the correct answer is that you have to maximize your effort in achieving a final diagnosis. And if the reason for the Minoca is a plaque-induced event, then of course you can go for antiplatelet therapy. Otherwise, it's just a waste of resources and potentially a threat for the patient.
Okay, thank you. Claudia would like to ask a very important question here about, so now with these results and the growing body of evidence in randomized trials, how would you choose the best strategy for this specific patient? What tools do we have to choose short DAPT versus de-escalation?
Yeah, thank you. I want to take the occasion to say that in this moment, the two guidelines across the Atlantic are again different, because the guidance from the ACC, AHA, and SCAI have been published recently, 2021, and now they advocate for short DAPT already at 1 to 3 months, while our guidance in Europe say 3 to 6 months. So this generates another inconsistency. How to choose? I think we have to be a little bit better in practice in risk stratifying our patients. We have to be mindful that in ACS, we are not just protecting the stented coronary arteries, but the patient as a whole. So not necessarily the coronaries, but also all the other vessels, carotids, peripheral, etc. So of course, there is the kind of patient where you want to do more actually than less, and actually you want to extend the APT or go for DPI. I think one of the things that I put on the balance is, of course, the complexity of the procedure, but then also the complexity of the patient, and the patient in terms of thrombotic risk, meaning that I will do something more rather than less in multi-vessel disease, in PAD, in CKD, just to name a few. And of course, it's very important to risk stratify bleeding risk. And we have some tools to do so. So the precise DAPT score, but also the ARC HBR app, which is very handy. And you can use it in order to select those patients in which after PCI you should consider a de-escalation or a short DAPT. In practice, just to address the question of Claudio, what I would do is to reserve short DAPT for the very high bleeding risk patients and probably go for de-escalation for all the rest.
Okay, thank you. Last couple of questions before we come to time. So a question from Marco. When is the time for de-escalation? 1 month, 3 months, or 6 months? And the follow-up question is with regards to ticagrelor at 60 milligrams. So this debate of 60 versus 90. If you could please give us your thoughts.
Yeah, so let's say for the de-escalation time in the available studies, the attempt was done already at 1 month. So essentially the evidence we have from tropical ACS starts from 2 to 4 weeks, and this is the only timing I can say that was tested. But of course, de-escalation at a later stage, I think it's absolutely reasonable. The decrease in the bleeding, of course, increases as soon as you start. In terms of this de-escalation from 90 to 60, I think it's very interesting, and perhaps this is one of those strategies we would include in this halved dose strategy that is worthy to be tested. So I would like to see a study of DAPT with 90 and then de-escalation to 60 for sure.
Okay. And final question from Aisha. Could you please, so coming back to some methodology, on fixed versus random effects models in meta-analysis as related to DAPT?
Yeah, let's say that the random model is more conservative and more likely will give you neutral results if a true effect doesn't exist. So the random model is used when we suppose there may be some heterogeneity across the trials. And again, it's standard practice to show both in order to see consistency, as in our case.
Brilliant. And I think that pretty much takes us exactly onto time. So just leaves me to say thank you very much, everybody, for participating, your questions, and stimulating a great discussion. Giovanni, great presentation, great summary for quite a big and large paper and detail. So thank you. It was a really nice presentation. And of course, Professor Capodanno, you really shared your insights, and we appreciate a lot your time answering all our questions for all of us fellows connected. So big thank you to all of you. And thank you especially for all the little methodological insights. I think we really find it very useful.
Thank you.
Thank you, and congratulations for what you do.
Thank you. Have a good day today, everybody, and bon weekend, and see you next week.